Welcome to our program, New Milestones in Changing Standards of Care in EGFR-Mutated Non-Small Cell Lung Cancer, expanding the benefits of genomic testing and EGFR-targeted therapy to early-stage lung cancer. It's really my pleasure to be here today and welcome my colleague, Dr. Alicia Sequest, Director of the Center for Innovation in Early Cancer Detection at the Massachusetts General Hospital, where she's the Landry Family Professor of Medicine at Harvard Medical School. And I'm Dr. Roy Herbst, Ensign Professor of Medicine, Chief of Medical Oncology, and Associate Director for Translational Research at the Yale Cancer Center. Well, we have an exciting agenda today. We're going to talk about Precision Oncology Accelerator, translating science, transforming practice in early stage EGFR-mutated non-small cell lung cancer. We're going to start by setting the stage with an illustrative case. Then we're going to explore the evolution of precision testing and targeted treatment of EGFR-mutated non-small cell lung cancer. We're going to navigate the nuances of clinical integration of EGFR-targeted therapy in early-stage disease settings. And then at the end, we'll revisit the case and how it's transforming practice with a discussion, synthesis, and conclusions. Let's get started. Let's start with a case. It is now my pleasure to turn things over to Dr. Sequest. Alicia?
Thanks. It's such a pleasure to be here today, Roy, with you. Here's a case that we can consider to open us up, and we'll come back to this and revisit at the end, having seen some of the latest data and talk about how we would manage. So this is a 67-year-old man who had a VATS right upper lobe lobectomy for a clinical stage 2A N0M0 lung adeno. On resection, there actually turned out to be a positive hilar node. So pathologic stage is T2A N1 M0, and it was a complete resection or an R0 resection. One question facing the community is, would you test the tumor for genomic alterations? In this case, that was completed, and the patient's tumor harbored an EGFR L858R mutation. So I think the question, the very prescient question now is, what therapy would you recommend next for this patient, and how would you approach clinical decision making? So I invite our audience to kind of keep this case in the back of their mind as we go through some of the data today.
I couldn't agree more, Alicia. There's so much new data from ASCO, ESMO, and now the World Conference of Lung Cancer. The International Association for the Study of Lung Cancer meeting just held virtually from Singapore. So let's go through some data.
So let's explore the evolution of precision testing and targeted treatment for EGFR mutation positive lung cancer, especially as it concerns early stage disease. So our audience is familiar with the results of adjuvant chemotherapy. This has been part of our practice for nearly 20 years to administer cisplatin-based chemotherapy, especially after resection of stage 1B, 2, or 3A non-small cell lung cancer. And indeed, there is a proven survival advantage, but indeed it is modest, depending on the study, anywhere up to 20% improvement for more advanced stages. But there is certainly room to improve this more, especially now that we have increased detection of patients with early stage lung cancer now and in the future, thanks to the increased uptake of lung cancer screening. In advanced disease, of course, with patients with EGFR mutations, EGFR TKIs are the standard of care, and that has been that way for many years. We've had updated studies and updated drugs over the years, varying our standard of care, but genotype-directed personalized medicine has long been the standard of care, both for EGFR and for other genetic subtypes of lung cancer. In fact, in lung cancer, we're very lucky to have so many different targeted possibilities for our patients. And in fact, there are currently 7 different genotypes or driver mutation positive settings where we have approved therapies. There are, in addition, other drivers which have very exciting therapies that are still under investigation, such as in KRAS G12C. In the metastatic setting, it is standard of care to test patients to look at their driver mutation and customize therapy towards that. And for EGFR in particular, historically we've thought of EGFR mutations as the classic activating mutations, and some of the more resistant to treatment mutations like exon 20. There are now therapies being developed for exon 20. And for the classic activating mutations, we've gone through a variety of different standards of care over the last 10 years as we advanced from first generation to second generation, and now most recently with the FLORA study, third generation EGFR TKIs in the frontline setting. Also, we're looking at combinations now for our patients, such as the FDA-approved Erlotinib and Ramaceramab, and several other combinations that are in clinical trial. But we have yet, until this past year, we have yet to translate those advances into the early stage setting. And while we've had a lot of supporting data, like the SELECT study coming through, showing that there is a suggestion of a benefit to give TKIs in the adjuvant setting, it wasn't until this past year, when we saw the results of Adora, which Dr. Herbst presented at ASCO, that we really saw in a randomized setting that this works. So with that, let me ask you, Roy, to kind of remind us about the exciting data from the Adora study.
Yeah, thanks, Alicia. And really, the whole idea now is to bring these targeted therapies to the earliest stage setting. And certainly, for years, the paradigm has been that you bring your best drugs early, and that's where you can cure patients, hopefully, with lung cancer. But the targeted therapies have never been brought early, certainly not EGFR inhibitors, until recently. There were some studies with Erlotinib, the RADIANT study, Erlotinib versus placebo. You can see the results here, published by Dr. Kelly. This was in the early days when EGFR mutations were first being described. You can see disease-free survival in an intention to treat population, all patients, not just those with EGFR mutation on the left. And then on the right, you can see those patients who are EGFR mutant. And you can see that there is a DFS advantage to patients that have EGFR mutation who get Erlotinib versus placebo, but the result was not significant. And then, as you just heard from Alicia, the SELECT study, a single-arm study looking at adjuvant Erlotinib and resected disease, showed some promising results, but of course that was only a single-arm study. And then from Asia, we have the Adjuvant Study, a phase 3 trial of adjuvant Gefitinib versus vinorelbine cisplatin in stage 2 to 3A disease and 1N2 disease. And you can see the DFS in the ITT population. This is a positive trial with a hazard ratio of 0.8. Unfortunately, the ultimate survival was not maintained. So positive DFS, but no survival benefit. So I think it's safe to say that there was equanimity here, that would an EGFR inhibitor in patients with completely resected EGFR mutant lung cancer, would it have a benefit? So that led to the Adora trial, which is a phase 3 double-blind study. You can see the study here. This is basically patients with completely resected stage 1B, 2, or 3A non-small cell lung cancer with or without adjuvant chemotherapy. You had to have age greater than 18 or 20, depending on where you lived, a good performance status, confirmed primary non-squamous non-small cell lung cancer, 2 EGFR mutations, exons 19 and 21 were allowed. Brain imaging had to be done, if not completed preoperatively. There had to be complete resection, R0, negative margins, and chemotherapy was allowed. If you had chemotherapy, the maximum interval between surgery and randomization was 10 weeks without adjuvant chemo and 26 weeks if the patient had adjuvant chemo. It was stratified for 3 things: stage 1B, 2 versus 3A. About 1/3 of the patients were in each group, by the type of EGFR mutation, and by race, Asian versus non-Asian. 2/3 of these patients were enrolled in Asia. And then it was a 1-to-1 randomization, 682 patients. And as I said, since there was no control, there was no data to support EGFR inhibitors in this setting, the control is a placebo. So it's osimertinib 80 milligrams daily oral versus placebo. The planned treatment duration, 3 years. Treatment to continue until disease recurrence, treatment is completed, or discontinuation criteria are met. Follow-up until recurrence, week 12 and 24, then every 24 weeks, to 5 years, then yearly. That's ongoing now. After recurrence, every 24 weeks. The primary endpoint of this trial was disease-free survival by investigator assessment in the stage 2 and 3A group, designed for superiority with a hazard ratio of 0.7. So a 30% improvement would have been a positive result. Secondary endpoints, DFS in the overall population, so add in the stage 1, and then landmarks at 2, 3, 4, and 5 years. Overall survival, of course, safety, and quality of life. We'll show some of that today. Now, honestly, I did not expect we would present these data last year. We assumed the trial had another several years to move forward. However, the safety committee met last April, and in reviewing the data, they were actually struck by the huge differences that they could see in efficacy, so they unblinded the trial. So this was an early unblinding of the trial, not planned, and those are the data that we presented. Well, here are the data that struck us. Just incredible hazard ratios. So in stage 2 and 3A disease, the primary endpoint, you can see the hazard ratio as shown 0.17, or an 83% reduction. Remember, 30% would have been positive, and you can see the early separation of the curves and all the way out, as shown in this analysis, quite a difference. And then when you add the stage 1B in, patients, who many of whom would have been cured on their own, you can see the hazard ratio just is a little bit higher, 0.2, or an 80% improvement. Across subgroups, we'll talk about this more. All the subgroups were to the left of the unity line, so all the subgroups positive: sex, age, smoking status, race, stage, EGFR mutation, and importantly, adjuvant chemotherapy. Whether or not the patient had the adjuvant chemotherapy, based on the choice of the physician and the patient, they still both benefited. And here is the disease-free survival per investigator assessment by stage. So as I mentioned, stage 1B, the earliest of disease, still a significant benefit at this analysis. Stage 2, significant, and stage 3, the biggest difference, and that's what you would expect, the biggest improvement in the patients that would do the worst without any therapy. And then here you can see assessment with and without adjuvant chemotherapy. And as I mentioned, hazard ratio in patients who received adjuvant chemotherapy, 0.16. In those who did not receive adjuvant chemotherapy, 0.23. And we recently showed at the World Lung Cancer Conference that this was evenly distributed by stage. As far as between the two groups, most of the patients who received adjuvant chemotherapy were the stage 2 and 3, and many of the stage 1s did not receive the adjuvant chemotherapy, as you would expect. Then importantly, adverse events. Very important to look at adverse events, especially when you're looking at an adjuvant therapy, because of course the control placebo should have no adverse events. So there is going to be some cost, but you can see the osimertinib on the left and the placebo on the right, and you can look, and there are very few grade 3 events. A few more, diarrhea, paronychia, dry skin, stomatitis, the things we've come to know about with EGFR inhibitors. But the big ones, interstitial lung disease, no grade 3 or 4 ILD. That was a big concern going into the trial, so that was good. QTC issues, no real issues there as well. So the conclusion, adjuvant osimertinib is the first targeted agent in a global trial to show a statistically significant and clinically meaningful improvement in DFS in patients with stage 1B, 2, and 3A EGFR mutant non-small cell lung cancer. Consistent improvement was seen regardless of whether patients received adjuvant chemotherapy, and the safety profile was consistent with established therapy with osimertinib. Of course, we already saw the FLORA data with mild EGFR TKI class effects reported. Well, I must say, having worked in this field for over 25 years now, I was extremely excited by these data. Of course, we're waiting for other endpoints, but the magnitude of the DFS just was quite large. So based on this, the FDA actually on December 18th approved osimertinib for adjuvant therapy after tumor resection in patients with non-small cell lung cancer whose tumors have EGFR exon 19 deletions or exon 21 L858R mutations, as detected by an FDA-approved test. So we've really come full circle. Over 20 plus years, we've taken EGFR inhibitors, We've defined EGFR mutations, their use in the frontline setting. We've now have a third generation drug, osimertinib, which is better tolerated, more specific, has CNS activity. And now we have these data that are resulting in its use in the early stages of disease.
Agree. It's fantastic. Congratulations, Roy, and to you and Dr. Wu and the entire team that worked on this study in a year where we had unprecedented number of approvals in lung cancer. I think that this one has the biggest impact in terms of its reach. I mean, we when we would talk about the benefit of adjuvant chemotherapy and show some of those Kaplan-Meier curves from those randomized trials, you would need a laser pointer sometimes to see the difference, the 5% benefit separation between those curves. But, when you were presenting these exciting results at ASCO, I tweeted out that I could do cartwheels between those curves. They separate so much. And that was because I was so excited for patients that I wanted to do cartwheels. I mean, this is really a significant improvement in outcomes for our patients.
Absolutely. And you can imagine that this could start a whole new paradigm. Why should it just be EGFR mutation? We have, 7 or 8 drivers now, in lung cancer. And many of them, should soon be, assuming the drugs are well tolerated, be explored in the earliest stages as well. So I think it opens up a whole new era in how we treat this disease. And it's taken time, but it's been, as you say, the clinical trials and defining how to use these drugs. Yeah, and I was actually expecting this trial to be positive, but this much really is striking. Of course, we have to continue to follow for survival. We have to continue to look at sites of recurrence and quality of life and some of the subsets, and we'll get to some of that in our discussion now. But I think it really it makes this available for patients, which is really great. And
for sure. Yeah, let me ask you this. You had mentioned that you weren't expecting these results to be ready so soon, and that they were presented based on a recommendation from the Interim Data Safety Monitoring Committee that they could see that there was a widening and quite significant difference between the groups. Now, one thing that I get asked a lot from my colleagues is, well, since the study was unblinded and stopped early, that's people's interpretation, how are we ever going to know the overall survival? Is that somehow tainted? Maybe you can explain a little bit more how that works in this particular trial.
Right. Well, of course, in early disease, we expect patients to survive, for a reasonable period of time. So with an early unblinding, with an early result, it's not surprising that survival isn't yet mature. Actually, there is in the supplementary data for the paper and shown at ASCO, there is an early survival curve, which actually does have significance, but it's way too early. There are very few events, as there should be. It is important to follow this for survival. And as we've unblinded, we've actually now amended the protocol with a mandatory or at least a crossover that we hope most patients will take advantage of. So we want patients, when they recur with metastatic disease, with local disease, that's not the indication for osimertinib. But if patients recur, no matter where they are in the world, and remember, this was an international, global, worldwide study, they now can get osimertinib on the trial. Because absolutely, we want to make sure that we preserve the blind. We're not unblinding anyone. Certainly, if they demand it, of course, and want to be unblinded, we will. But the feeling is anyone who's on the placebo arm right now, and everyone was more than a year on the drugs at the time of the unblinding, they're doing well. They should stay on that. And anyone who recurs now on the trial, they will get the drug. Is it perfect? No, but it's the best we can do now to preserve the integrity of the survival number. And I predict the survival will, come together a bit, as it often does. But I think, as we'll see in some of the data we're about to talk about, the fact that when you recur with this disease, and you and I, have been sharing patients for years, and we've actually used this, at least I have on occasion, in selected patients, because when these patients do recur, they recur in the brain, the liver, the bone, which is very hard to salvage, even if you could get them an EGFR inhibitor at that point. So I'm hopeful for survival. We're continuing to monitor it. And there'll be much more data from this trial in years to come as we analyze it in the most pure fashion we can.
I think both of those points that that you mentioned are really important, Roy, about how while the data is unblinded, the patients and their treating physicians are still blinded. So patients are still taking either osimertinib or placebo. And then if they do recur, no matter which arm they were on, they will have access to osimertinib. So I think from a scientific and design perspective, we actually will have very good data, hopefully enlightening data about the overall survival, but that will still be several years away. For patients, I couldn't agree with you more that the CNS is a very important topic when thinking about lung cancer in general, and certainly for EGFR mutation lung cancer. It's a common place of metastasis, and for early stage patients who've had surgery, it can be a common site of recurrence. It's a very can be a very morbid situation if it occurs. So if there's anything that we can do to improve control in the brain, that's very important. And that's certainly been a paradigm. One of the, I think one of the reasons why osimertinib has been successful in patients with metastatic disease. So what about with the Adora population? We saw data from this presented at ESMO in 2020. And on the Adora study, the patients that have recurred, which is more in the placebo arm, of course, than in the osimertinib arm at this time, but we can see that the type of recurrence was also different. So even among those that recurred in each arm, the proportion that recurred in the CNS was skewed, and we saw that 11% of patients in the osimertinib arm and 46% of patients in the placebo arm have recurred, but that also the majority of recurrences in the placebo arm were distant. And when we look specifically at the site of distant recurrence, the percentages of those that recurred in the CNS was 10% in placebo compared to 1% in the CNS, 1% in the osimertinib arm. This is really consistent with what we've seen in the metastatic setting. This drug has very good CNS penetration and a very good ability to protect the brain from recurrence. It is really early days when we're looking at this presentation from ESMO, which is, I believe, part of the manuscript in the New England Journal. But even this early cut is a quite significant difference in the CNS disease-free survival with a hazard ratio of a 0.18 and a p-value of 0.0001. So it's quite clear that that the CNS is going to be an important arena to think about for patients here, just as it is in those with metastatic disease. I think one important thing, I'd love your take, Roy, is the fact that all patients in this trial also had CNS imaging before they went on. You mentioned that in your presentation. That's not necessarily the case, especially in other trials, especially when you're talking about a global trial. CNS imaging and MRI machines in particular are not available. We're spoiled in the US. We think that they have them at every hospital, but they don't worldwide. One of our other recent trials that changed the standard of care for early stage disease, the Pacific study, which was looking at a high risk for CNS met population, stage 3 patients. They didn't require any CNS imaging before the Pacific study. In Adora, all patients had CNS imaging. I wonder how you think that may have impacted the study or made a difference in interpreting these CNS results.
Right. Well, I think the fact that we have imaging on all patients is wonderful. Of course, some might say, well, some had CT, some had MRI. If you look at the data, we actually just presented that at the World Lung Conference. It was about 50-50. And certainly, it is possible that, you miss something with a CT or a CT contrast versus an MRI, something very small. That said, it was randomized. And it was, so I think the randomization is a big factor here. It was a rather large study. Certainly, we'll need to follow the data as it matures. But my feeling is, the difference is so large, and with the randomization. And again, remembering this is a real world study. This is not everyone has, like you have at the Mass General, 20 MRIs in the basement, or we have quite a few here too. So it's not something that can be done in all places. So I think it still is a very relevant result. Certainly we'll continue to follow it as the trial matures. I think the randomization is a big thing to remember, that, different techniques, but in a randomized way, equal between the groups. So that's just my take, but certainly we'll continue to update the data as time goes on.
Yeah, I agree completely. I think it's commendable that all patients were imaged, and that's certainly not the standard of care for some of our other, or the standard of trial design for some of our other trials. So I think it gives us robust data. Patients were pretty unlikely to have had a CNS Met that was not known about, and to have actually been stage 4 and put on the trial. I think that's going to be pretty uncommon. One other difference that you had mentioned when you went through the original data here was about the chemotherapy use, and how that was not necessarily mandated, but it was up to the patient and the physician if it was appropriate based on their case. Some have asked me, some of my colleagues in the community have asked me how that impacts our interpretation. And one question that I hear a lot that makes me a bit nervous is, should we just forego chemotherapy and think only about EGFR TKIs for these patients after surgery? What are your thoughts? And maybe you can review for us what was just presented at World Lung.
Right. Well, a couple of things. The adjuvant chemotherapy is important. Again, a randomized trial and equal between the two groups. You can ask, why did only 55% of patients get adjuvant chemotherapy? If you look at the data just presented at World Lung by Dr. Wu, you can see that 80% of the patients who were stage 3 received adjuvant. That's actually consistent with what's been seen in other adjuvant trials around the world. Many of us would say 3A, everyone should get chemotherapy, but there are reasons, either a patient condition or choice, that don't allow that. In stage 2, 71% received adjuvant chemotherapy. Again, something that is variable and a discussion we all have. And then, as you would expect, in the stage 1B, only 26%. So the question is, what about removing the therapy completely, the chemotherapy? I would say, hold on. These data do not address that. We will look at the subsets of patients, in this trial, but they're going to be small numbers. So I'm not sure we'll get the answer from the Adora trial. Remember, the trials in Canada, the trials around the world, the meta-analyses, they've all shown that adjuvant chemotherapy improves survival in locally advanced non-small cell lung cancer. Now, the improvement's only in the 5 to 10% range. We looked at this at the very beginning, but it is real and significant. So my feeling is that if someone is what you believe to be a candidate for adjuvant therapy, I would still use the adjuvant chemotherapy, followed by the osimertinib. In fact, I have a woman who's coming in tomorrow. She's been asking me that exact question because she'd love to get rid of the chemotherapy. I understand that. But that said, I think right now, another trial could be done. But at this point, given the survival benefit of adjuvant chemotherapy, I would not remove it. What would you do, Leisha?
Yeah, I agree completely. And, I think the percentage of patients on a stage by stage basis that received chemotherapy is fairly reflective of practice. Just as you say, not everybody receives chemo, but it is appropriate, and I think a good basis to build on and test the adjuvant OC question with the percentage of patients that got chemo. And it's most important that stage 3A patients get chemo. They have the biggest benefit from it. And indeed, as you're showing here, 80% of patients with stage 3A got chemotherapy. I agree with you. I do not think that these results tell us it's okay to forego the chemotherapy. And I still recommend chemotherapy for everyone for whom it's appropriate. But I think the flip side is that if you do have a patient who's not appropriate for chemotherapy for whatever medical reason, that doesn't mean you can't give adjuvant osimertinib if they have an EGFR mutation. I think what we've seen from Adora is that there is a benefit to adjuvant osimertinib regardless of whether you got the chemotherapy. So if you have someone who's not a candidate for chemo, you can still think about this. It's not an excuse to forego chemo if the patient's appropriate.
Agree completely. And and now that we're making these decisions in practice every day. It's again, we're screening most of our patients now, if not all, at surgery for EGFR mutation, so that we can have that discussion with the patient.
One of the other things that was shown at World Lung was the patient-reported outcomes and the quality of life, which I'm just starting to treat patients with this ever since ASCO. I've been treating patients with adjuvant osimertinib, but as an investigator on the trial, I assume you've had a little bit more experience under your belt. How do patients tolerate adjuvant osimertinib, and outside of your practice, what did the overall study results show us about PROs?
Right. Well, adjuvant therapy is a totally different game than metastatic disease, because you don't have to do anything. So anything's going to add a toxicity. So by definition, there are going to be a few more side effects with a drug versus a placebo. And certainly in the absence of the survival result, which, as we talked about, we'll have to wait a couple of years for, people do ask, at what cost, is this drug, and how will it affect how I feel 3 years of taking a pill? And as we showed that while the side effect profile is quite mild, there are admittedly more side effects for the drug than the placebo. The skin and all early grade, the skin and the diarrhea, but still early grade. You and I have been working together. I won't say how long, but it's been a while since we met with Tom Lynch at the Mass General, and we used to have our meetings, and we were first doing all these studies with the EGFR inhibitors, and now they do have toxicities that we've learned to manage. So you have to be honest with the patient about that. Now, one thing that was done was a quality of life analysis. Now, I've got to tell you, I've been doing this a long time, and in almost every randomized phase 3 trial I've done, there's been a different quality of life metric. And there are people who study this, but I will say that it was important to do a quality of life analysis here, and that was presented at the World Lung. And not to go through all the details, because it's quite complicated, and there'll be a manuscript on this pretty soon, or one could go to the World Lung site. But they used a quality of life measure in the trial called SF-36. And you can imagine how much work this is. 5, 6, 7 languages, around the country, around the world, trying to make this work. And there were two different criteria here: physical criteria and mental criteria. And just my understanding of this, not being, not my expertise, but I certainly believe it's important, is that this has been used in other studies. So you have a standard of what's considered a significant, decrease in quality of life. Because there is going to be a little decrease, but is it significant enough to say that there's a problem? Well, just a couple of things. Top line data on the quality of life. Compliance was really good, and it was good across the trial. But it did stop, when patients came off the study. So that's one thing to keep in mind. And it started when the patients were randomized. So it's not completely throughout the course. And then if you look at baseline scores, they were pretty consistent between the two groups. And then if you look at the change, there wasn't much change. There was a slight diminution, but for the most part, both in the physical and the mental scores, the changes were quite modest. And if you look at time to deterioration across multiple domains: bodily pain, general health, mental health, physical functioning, emotional and physical feelings, social functioning, really the changes were all quite mild. And did not hit a significance level compared to what would be considered a significant deterioration of quality of life by this measure. So the bottom line from this analysis really was that quality of life, for the most part, was maintained, despite the fact that patients had between 0 and 3 years of drug, of course, different variables. But so far, quality of life seems to be reasonable. Now, of course, you have to ask any given patient. I'm sure there are some patients who are having a tremendous rash or a problem who might want to stop or be dose reduced. There were about 10 to 11% of patients who needed to be dose reduced. But for the most part, this quality of life measure, to my analysis, and I've looked at it multiple times, is that it really maintained quality of life despite giving an additional drug over a placebo. And then, of course, given the large benefit, in terms of the hazard ratio, I personally believe that that's enough to justify using this drug as we await for the survival number. Certainly, ultimately, you're going to want to show survival. But remember, this quality of life measure probably does factor in that patients, when they recur, as we just heard from Alicia, will recur in the brain and other sites of great morbidity.
That's been my experience so far too for patients, that it is something that is doable and is probably going to be doable for 3 years, which is the duration of treatment on the Adora study. Having treated many patients with adjuvant Erlotinib for 2 years on the SELECT study, that can be quite difficult to get through 2 years of Erlotinib. And Jamie Chaft, Joel Neal, and I just published a week or two ago a trial that we ran of adjuvant afatinib, and let me tell you, that was quite difficult for patients to get through. So, to see this quality of life data, and we all have quite a bit of experience now with osimertinib in the metastatic setting. The quality of life and the feasibility of doing this adjuvant treatment is important, and I applaud you for collecting this data along with the study.
Yeah, I was really impressed, again, worldwide, how good the compliance was. And, it speaks, and now I think it's going to get even better, because with the COVID and everyone moving to telehealth, I'm seeing more and more people using tablets, and I think that's going to be, and we did use tablets for some of this collection, but can you imagine now, it'll be even easier, hopefully, to get PRO data. And after all, that's what matters. And, I talk to a lot of patient groups. In fact, we're doing a program in a few weeks with patients discussing the approval of the drug. And, patients want improved survival, disease-free survival, and they're very focused, as they should be, on quality of life. So it is very important, especially in an adjuvant trial, to continue to look at this. The one nice thing about these third-generation EGFR inhibitors is, as we talked about, they're EGFR mutation receptor specific. So not perfect. There's some crossover, but clearly, I don't think one could have done 3 years of gefitinib or erlotinib like this with the same result. And that's probably one of the reasons why some of the earlier studies I mentioned were not nearly as positive. Also, of course, the CNS penetration has a role as well.
So let me ask you this. The Adora study, of course, you had to have a deletion 19 mutation or an L858R mutation to enroll. But we have seen in patients with metastatic disease that osimertinib can be very active in some of the other less common but still activating mutations. I'm thinking about G719 or L861Q. 768I is one of the most sensitive mutations, but it's not found that often. Would you extrapolate this data to patients with other EGFR mutations?
Well, personally, I would say yes, although that would be an off-label usage and may not be reimbursed. But if you have a mutation where the tumor it's active, the osimertinib is active in the metastatic setting, I see no reason why one could not extrapolate. Where I wouldn't extrapolate would be a mutation where one knows that there is very little activity of osimertinib in the metastatic setting. And I think for simplicity, this trial took the two most common, or what do we say, Alicia, canonical EGFR mutations. But I think I would, on a case-by-case basis, extrapolate and try to get an approval to use the drug if the patient were willing. What would you do?
Yeah, I agree. I think we have to be careful to pull exon 20 insertions out of that group, because at least at 80 milligrams a day, osimertinib is not as active in exon 20 insertions. But for some of these other mostly point mutations, I would agree. A lot of my colleagues have asked me one step further, would you extrapolate this data to other drivers? Like, for example, if you had a patient with resected ALK positive lung cancer, can we use Adora to support giving adjuvant alectinib? And I hesitate much more on that point, although to be honest, I think the biology is probably similar. I think if you had conducted a trial in that setting, it would probably show very similar results, at least with some of these highly specific, well-tolerated CNS penetrant drugs, like, for example, Erlotinib for ALK patients. But we don't have the data yet, and the Adora data is still early. Do we have the patients and the time to do a trial like Adora in every single setting? Not only ALK, but ROS and RET and, all of these NTRK. I mean, that could take us 100 years to do an adjuvant trial in the NTRK
Our
setting.
grandchildren will do it, huh?
I don't think it's fair for patients to have to necessarily recreate the wheel every time. But I'm not quite ready myself to pull the trigger and prescribe adjuvant Erlotinib or any other inhibitor. But I think that's something we're going to have to grapple with over the coming years, especially as Adora matures, especially if we see overall survival benefit.
Well, I agree with you. I think, we do have a new paradigm here. And, the big shift is, when do you do your next gen sequencing and your profiling? And, so clearly, if, we live in the United States, EGFR mutations are only 10, maybe 15% of the patients, maybe a little bit more if you have a Asian non-smoking population in your practice. So we just need to make sure we screen for these. But, at the same time we're screening for these surgery, we can screen for everything else, and we should. Now, can we extrapolate to ALK and ROS? I don't think we can yet. I think they're different drugs, although they are drivers and addicted drivers where you still get this 80+%. Some people have even talked about extrapolating to RAS. Then I would say, whoa, if you have something where you're only 30-40%, it's a little different. Maybe someday it will work. Maybe there's combinations with chemotherapy, but I would say let's do the trial. And dare I use the word master protocol. But this sort of begs itself for some sort of program where supported either by insurance or CMS or a public-private partnership, we have a protocol where patients are all getting screened post-surgically, and then the drugs are available. And that would be great, because it's some of these drugs are not approved yet, and none of them in that setting. And let's do the trial and do the study. But I think there'd have to be randomized studies. We don't want to, again, we want to bring these drugs to patient benefit as quickly as possible. But we need to look at safety, tolerability, how would those drugs do, in someone in the adjuvant setting, and also look at the result. So I think it's all promising, and I think we're going to see all these trials. In fact, some of them have already crossed my desk. I'm sure the same ones have come by yours. So I think we'll see that soon.
Yeah, at the same time, we've had a type of master protocol, the Alchemist platform, in the intergroup setting now for many years, almost 10 years. And that study has had trouble looking for resected. At first, it was EGFR patients who were going to get adjuvant Erlotinib, and then we added on an arm for adjuvant crizotinib in patients with ALK positive cancers. And that trial has had a lot of trouble accruing, other than to the non-matched adjuvant immune therapy arm. What are your thoughts about that?
Well, that trial actually used survival as its endpoint and not DFS. So they set their bar even higher. And I know the NCI felt quite strongly about that. I think the Erlotinib arm of that has now closed. Given that the Osimertinib is now approved, which is a shame. It would have been nice to have seen that trial complete. But again, you're looking at small populations. Assuming everyone gets screened, it's really only 10% or so of patients in the U.S. If you're doing a U.S. only trial, maybe a little more if you pick a selected population. And then for the ALK, what is it, 3 to 5%? You seem to see all of the ALK at Mass General. So, for the rest of the world, how many ALK patients does a general oncologist see? A few, but so it's tough to accrue those arms. I will tell you that the Alchemist trial, what it has done is the nivolumab arm, that's accrued incredibly fast. So there you're using immunotherapy, albeit without a marker. So it's an important trial to do because of the amazing benefits we're seeing for immunotherapy. It'll be interesting to see in the adjuvant setting without a marker, whether or not it's a positive or not. I'm sure that there will be some retrospective data on PD-L1 status, but those things need to be done. And it is a shame that those studies haven't accrued faster. We actually have it open here.
Yeah, we have it open too, but we've had trouble getting patients on and finding the ALK patients, I must say.
We need to all collaborate and come together and do these trials. And they're important ones to do. The other thing we haven't talked much about, but I just want to bring up, is resistance. So one of the things I often hear is, if I use my EGFR inhibitor now, what will I do when the patient becomes resistant? And I don't know what your thoughts are on that, Leisha.
Yeah, I think this is an area where we do have some data from the SELECT study. SELECT was done in an era before osimertinib. So those patients who received, two points I would make. One is that the patients who received 2 years of adjuvant erlotinib, very, very few, just 1 or 2 patients recurred while they were on the adjuvant erlotinib. And those patients did tend to have what we classically saw as resistance in the metastatic setting, which was T790M. But the much more common scenario for patients on SELECT was that they would recur at some point after 6, 12 or more months after their course of adjuvant TKI had completed. In that era, when we did the study, there was no other EGFR inhibitor to give. Most of those patients had a biopsy to prove that the recurrence they had was still EGFR mutation positive, and none of those cases that recurred later had T790M. So it wasn't that the disease was resistant, it was that we were maybe suppressing the disease, and when we stopped the suppressive TKI, then they got a recurrence. But in that group of patients, they were re-exposed to erlotinib, and they were still extremely sensitive, had a very robust response and progression-free survival. So, of course, we need to collect the data, but I would expect that that paradigm will hold, and that if patients do recur after their course of adjuvant osimertinib is over, that does not mean we should withhold osimertinib. In fact, most patients, if the analogy holds, most patients will probably still be sensitive to it.
I agree, and for those that aren't, we'll need either tumor biopsies or liquid biopsies to understand what the resistance mechanisms are, and that's, of course, work that both of our groups are doing right now to continue to try to find new combos or new drugs for that resistance. So why don't we go back to our case, Leisha? You read through it last time. I'll do it this time. So we have still our 67-year-old man. He's only aged about 30 minutes and has a VATS right upper lobe lobectomy for stage 2A N0M0 lung adenocarcinoma. The P stage is T2A N1M0, and it's an R0 resection. Would you test the tumor for genomic alterations? Okay.
Absolutely. And as soon as the Adora results came out, we at my hospital, we began working with our pathologist to make testing for EGFR reflex on all of our resected cases. I mean, I think in each setting, wherever you practice, you're going to have to work with your local collaborators to figure out the pathway that makes the most sense. But I would say we should be testing all resected adenocarcinomas given this data.
So you test and you have an L858R. So tell us a little bit about that discussion you have with a patient about risk benefit and how you would present it.
For each patient, I talk separately about chemotherapy and whether I would recommend it, and then for osimertinib and whether I would recommend it. And in this patient who did have an N1 node, and presuming that they're otherwise healthy, I would recommend both chemotherapy, up to 4 cycles of cisplatin-based adjuvant chemotherapy, probably cisplatin pemetrexed. And then we would plan to follow that up with 3 years of osimertinib. And I try to explain to the patient that there is a survival advantage to the chemotherapy, that it actually increases the cure rate, and that the data with osimertinib is new. We don't know yet if it increases the cure rate. What we have seen is a very dramatic increase in the amount of time until recurrence, if recurrence is going to happen, and a good tolerance and a decrease in the chance of brain mets happening as a site of recurrence. So most of the patients that I've discussed with so far have been on board with that.
Well, it's been a great discussion, Alicia. We're getting some questions from the audience. Let's go over a few of them. So the first deals with molecular testing, and now how do we optimize this in advanced disease? Is it easier when you have a resected sample? Should we reflexively test all patients with lung cancer at surgery?
This is a great question. And every time people present real-world data about how well we're doing with molecular testing in our advanced stage patients, I am floored that, nationally we do pretty poorly. It's been 16, 17 years since EGFR mutations were discovered and described. And, at this point, it should, I think, be absolutely the standard of care to test every patient with advanced disease, and yet we're really falling short. So on the one hand, it seems like a no-brainer to just implement this in early stage disease, but I think we have to realize that we're not doing this well in advanced stage disease. However, your question about whether this is maybe easier in early stage disease, I think there's some merit there. For one thing, there's already a relatively large chunk of tumor that's going to the pathology department. It may be easier to standardize also reflex testing in a surgically resected setting compared to, an oncologist that sees patients with advanced disease. They may have biopsies coming in from multiple different hospital settings. Some of them may be FNAs, some of them may be bone biopsies, which aren't great for genetic testing. So it may ironically turn out to be easier to do, but each setting is different. And so I think it's really incumbent on both the oncologists and the surgical oncologists, now that we have this data on adjuvant osimertinib, to really work within their systems and figure out a flow that makes sense in their local environment, because I think it now should be standard of care for all patients with early stage disease to get molecular testing, at a minimum EGFR testing.
I agree, and we just had tumor board this morning, and we now discuss, does the patient have any relevant mutations in early disease? And it's going to take a while, but hopefully much quicker as more places now have next gen platforms and are doing mutation testing, and programs like this and others, getting the word out. So I look forward to increasing the denominator here so that more patients have the potential to discuss and benefit from this therapy.
So there's another question coming in from the audience. Is osimertinib the preferred first-line agent for newly diagnosed metastatic non-small cell lung cancer? And do you see any role for combination approaches in the adjuvant setting? So, I think this question is building off of the fact that there are some interesting things being studied in the metastatic setting, like EGFR TKIs and VEGF inhibition, or EGFR TKIs and chemotherapy. As those results mature, and we already do have an FDA approval for Erlotinib and Ramaceramab, how do we think about that data for our early stage patients?
Well, I think that you're going to want to use your best therapy for adjuvant, but again, remember the tolerability is an issue, and we talked about quality of life and side effects. My feeling right now is osimertinib is the preferred agent. It's the approved agent, and should be used as such. However, the data with the VEGF inhibitors is interesting, and we do know that patients become resistant. So despite the fact that this is a great drug, there are still patients progressing with DFS on the EGFR therapy arm. So I think it's going to be very important to look at what the resistance mutations are, why these patients are becoming resistant. I think we're going to start looking at minimal residual disease and liquid biopsies, and that will tell us early on what's happening and and who's resistant and who's not and why. So I think ultimately there will be combinations here, or even a next generation drug, and those will need to be studied, as such, in clinical trials. But right now, I would say let's continue to refine our therapy in the metastatic setting. Let's understand a little bit about why patients are becoming resistant, and then when the time is right, I do think we'll move some things up. But right now, I think I would not do any mixing and matching, in my practice. What about you?
Yeah, I agree. And in my practice, even in the metastatic setting, is still to primarily use osimertinib. But certainly in the adjuvant setting, I think it's too early to take any of these other combination regimens into that venue.
Yeah, here's an interesting question, and this came up all the time here at Yale. So the trial did not allow any radiation therapy, and that was a compromise. You can imagine, in an international trial, the three leaders of the trial, myself, Masahiro Tsuboi from Japan, and Yilong Wu from China, and there was a lot of concern in Asia about interstitial lung disease, and no one wanted to use radiation. Now, of course, port radiation is something that usually takes 10, 15 minutes at every tumor board, right? Because it's been so controversial and the data were plus or minus. We now have the lung art trial. But at least when this trial was done, there was no radiation. And I can tell you that, it had been the practice in N2 disease. I trained at Farber, I was at MD Anderson, and now at Yale, where we would use radiation in that setting, especially as the techniques have gotten better. So what's your thought about port radiation, the fact that it wasn't in this trial? What would you do now? Some of the newer data that emerged at ESMO.
Yeah, I think this is one of the most complicated aspects of interpreting this trial, especially like you coming from an institution where radiation is thought to be a cornerstone of treatment for stage 3 disease. The lung art trial did, I think, give some reassurance, showing that post-op radiation in resected stage 3 disease did not help and may have even harmed. Like many global studies, I think part of the reason for harm in that study was the general way that the radiation was given. It wasn't 3D conformal, or didn't, maybe hold up to some of the modern standards of highly specialized centers. But nevertheless, I think it did provide some reassurance that this study, Adora, was based on a very reasonable standard of no radiation. But in my practice, I have to say that if I have a patient with borderline resectable stage 3 at diagnosis who, maybe has a enlarged N2 clinically apparent disease, I still do think that the best chance for successful surgery is to do neoadjuvant chemoradiation. And that doesn't quite fit into the Adora paradigm if they have an EGFR mutation. I mean, I'm anxiously awaiting the LAURA study, which will help us, not for operable patients, but for definitive chemoradiation, look at the role of consolidation. Osimertinib, I suspect, also based on some institutional data we have for stage 3 patients that we just presented at World Lung, that ultimately the best strategy for a stage 3 patient who needs radiation is going to be a combination of EGFR TKI and radiation and chemo and maybe surgery. The question is really how to order that. And these are the types of nuanced questions that are really hard to answer in a global randomized trial. I think that for the bread and butter patient who doesn't have clinically evident N2 disease, but turns out to have incidental N2 disease on resection, that based on both lung art and Adora, we can feel very comfortable proceeding with chemotherapy and then osimertinib and not worrying too much about the radiation. How about in your practice?
I agree. I think that I'm good in most cases now to avoid radiation, depending on the case. If we discuss at a tumor board, and if there is a concern about the resection margin, And I think we can do a little bit better with some of our radiation than they did in lung art because of the fields and having less heart and less a normal lung. I'd even be comfortable doing radiation, breaking from the Adora a little bit and doing radiation in selected cases. But that's my own personal opinion. It's not on the label, but it's something I would do.
Well, I think you and I could probably talk about this all day if we were allowed the chance. There's so many things to dissect about this study and about the changing paradigm. But unfortunately, I think we're out of time. So it's been really great to discuss Adora and all the related data with you, Roy, the PI of the trial. I think for our viewers, I hope you learned a lot today. I think what we've covered is talking about the Adora trial, a randomized placebo-controlled study of adjuvant osimertinib given at 80 milligrams for 3 years to patients with resected stage 1B, 2, and 3A lung cancers that harbor an activating EGFR mutation, specifically deletion 19 or L858R. We've seen that the study was stopped early for a very dramatic and significant improvement in disease-free survival. Overall survival is not yet mature, probably won't be for several years, but the way that the study is designed, I think we will be able to eventually see that data and interpret it. What we've seen so far is an improvement in CNS control and maintenance of good quality of life for patients on the study. And our challenges going forward into practice are one, to recognize these patients to make sure we're doing the proper genotyping for patients with surgically resected disease, and then to figure out how to improve this concept and take it forward into other genotype-directed areas of lung cancer. So really exciting advances in 2020. This is something that is definitely changing patient care today. It's been a great pleasure for me to discuss this with Dr. Herbst.
And I echo that. It's great to work with you, especially all the seminal work you've done in this field that had brought us to the point that we could then take it to the adjuvant setting. So it really speaks to how science can drive clinical studies and improve patient care. And we've come, you and I have seen how far we've come, but there's so much more to do. And now we talk about some of the other targets. So I look forward to working more with you, Leisha, and it's been great to be here today.
Thank you and good evening.
This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.